Today's content and presentation is on promoting urinary elimination. This is covered in your textbook on page 541, chapter 29. This presentation will bring to you information and knowledge so that you can actually take this information and knowledge to the clinical setting. You'll hopefully gain education and skills in how to assess your patient's urinary status, learn to perform a urinary dipstick test accurately, learn how to teach a patient in obtaining a clean catch urine specimen, assist your patient with toileting, as well as acquiring information and knowledge on how to insert an indwelling catheter using the sterile technique. So, which structures are involved in the urinary elimination? The structures involved are your kidneys. The kidneys are two bean-shaped organs located at levels L1 on either side of the spine. That's lumbar 1 on either side of the spine. Each kidney actually contains approximately 1 million nephrons. These nephrons are the working units of the kidney. Additional structures of the urinary system include the ureters, bladder, and urethra. The ureters are hollow tubes that carry urine from the kidneys to the bladder. Each ureter is about 25 to 30 centimeters long. The bladder is a hollow muscular organ located in the lower part of your pelvis that stores the urine. The bladder can actually hold up to 1,000 to 1,800 mLs of urine. An average urine output is 1,000 to 1,500 mLs per day. So the urethra. The urethra carries urine from the bladder to the meatus. The meatus conducts urine to outside the body. So in your textbook, page 542, you can find figure 29.1. This is a picture of the structure of the urinary system. You see the kidney here to the left and the kidney to the right. The ureter, the bladder, and then the urethra. (29.2) shows the tract of the male urethra. Okay, so we did an overview of the structure of the urinary system. So now let's talk about the function of the urinary system. Our kidneys filter blood through the nephrons. Remember I told you that the nephrons are the working system of the kidneys. Metabolic waste and excess water are actually extracted through the kidneys. The kidneys regulate electrolytes in the body by excreting excess amounts. This actually assists in acid-base balance by retaining or excreting the hydrogen ions and bicarbonate ions. Waste products are diluted with water and excreted in the urine. The tubules excrete, or reabsorb electrolyte waters and other substances. So our kidneys manufacture between 1 to 1.5 liters of urine on an average in 24 hours. This urinary output is related to the amount of fluid that we actually take in, and this can certainly vary depending on how much someone actually does consume. The bladder can store urine and send signal when it is full. Our bladder empties when 250 to 400 mLs of urine is present. This is under voluntary control. So some of us have a capability of holding on to more urine than that, depending on our situation, right? So as I mentioned previously, the bladder can contain 1,000 to 1,800 mLs of urine. On an average, the urine output for an individual can be between 1 liter to 1.5 liters per day. Again, the urethra carries the urine from the bladder sphincter to the meatus. Internal sphincters relaxes with micturition or urination reflex. The external sphincter is under voluntary control. At least 600 mLs of urine must be excreted per day to remove waste products. This is really important to remember. So remember, it's important that an individual excretes at least at a minimum 600 mLs of urine per day. If not, complications can occur. So what are some factors that might interfere with the individual's process or ability to eliminate urine? Some issues may include blockage. Blockage of the ureters prevent the urine from actually leaving the bladder. Blockage may occur because of the presence of stones in the ureter, pressure from an abdominal tumor, or even abdominal trauma. Additional injuries or complications that may prevent urinary elimination could be trauma to the urethra, an enlarged prostate, actually an infection of the urinary tract system, or some kind of neurological damage. Okay, so the great joys of becoming older, right? So unfortunately, our body does undergo some changes with aging. And what are some changes with aging associated with the urinary tract system or the elimination process? So with aging, there can be a decrease in the number of functioning nephrons. So remember what I said before, the nephrons are the working units of the kidneys and is involved in filtration of blood or filtration, period. So with that said, if there's a decrease in the numbers of functioning nephrons, there will be a decrease in the filtration rate. Also, unfortunately, some may experience decreased bladder tone. Decreased bladder emptying can occur, which may result in increased urinary residual. With aging, some may unfortunately experience enlargement of prostate, which will ultimately present with urethral obstruction. And also, incontinence can certainly be a complication with aging, although incontinence is not necessarily a normal part of aging. So urinary elimination, when it's considered normal, this frequency actually varies depending on an individual's age and stage of life. So the infants void 5 to 40 times per day, whereas preschoolers may void every 2 hours. Adults every 5 to 10 times per day. The total volume excreted by a male can be anywhere between 300 to 500 mLs each time, and the adult female may void 250 mLs each time. There should be at least an hourly urine output at the very least of 30 mLs per hour. This actually reflects adequate kidney perfusion. So if an individual is excreting or has a urinary output of at least 30 mLs per liter, you can presume that they have adequate kidney perfusion. If an individual has less than 30 mLs of urinary output, there may be inadequate kidney perfusion. So urinary elimination is affected by a few factors. It can be affected by neurological and muscular development, alteration in spinal cord integrity, the volume of fluid intake consumed by an individual, the amount of fluid lost by either perspiration, vomiting, or diarrhea, and also the amount of antidiuretic hormone, or ADH, secreted by the pituitary gland. So this slide is an important takeaway for you as a nurse because you're going to bring this to the clinical practice setting as well. When you're assessing your patient's urinary elimination status, not only are you concerned with your urinary output and how much of an output they have per shift or per hour or whatever the case might be, you're actually going to be looking at the characteristics of that urine output. So first you want to look at the color. Is the color normal? So what does that mean? Normally, urine appears straw colored in nature or amber. Anything darker than that may be indicative of urine that's concentrated. If it's smoky red or dark brown, this may indicate also that there may be presence of blood, or referred to as myoglobin. Remember to report any abnormalities to the physician or to the RN. When looking at the urine, you're looking at clarity. Is it transparent or only slightly cloudy? Also, normal urine should smell faintly like ammonia. If this urine is foul, there may be an indication that the patient may have an infection. So specific gravity refers to the thickness or thinness of the urine. Normal range is 1.010 to 1.030. This condition, but conditions such as dehydration or fluid excess may extend the range slightly in either direction. So urine acidity or alkalinity is actually measured in units called pH. The pH of normal urine is slightly acidic, which ranges from 5.5 to 7.0. Alterations in urinary elimination patterns. Familiarize yourself with these terminology. In box 29.1 in your textbook on page 544, you will find these terminologies and definitions. Anuria is referred to when there is less than 100 mL of urine output in 24 hours. Dysuria refers to painful or difficulties during the urination process. Dysuria may be indicative of infection or some kind of trauma. And incontinence. Incontinence is the involuntary release of urine. Nocturia. This is when a person has to get up more than twice in the night to urinate or to void. Oliguria refers to a decreased output less than 400 mL of urine in a 24-hour day. Polyuria is the complete opposite, is excess urination resulting in greater than 1,500 mL of urinary output in a 24-hour period. So what is cystitis? Cystitis is a common urinary tract infection which includes inflammation of the bladder. Cystitis may be caused by an irritation of highly concentrated urine, the presence of pathogenic bacteria, or injury. Symptoms of cystitis are as follows. There may be an increase in frequency of urination, increase in urgency, the presence of dysuria, burning, malaise, foul smelling, and also there may also be a slight temperature elevation. So collecting urinary specimens. Normal voided specimens are sent to the laboratory within 5 to 10 minutes. Urine that stands for 15 minutes or more may changes the characteristics, therefore the urinalysis would not be accurate. Urine specimens can be collected midstream. This procedure is obtained for cultures and sensitivities when a UTI is suspected. Specimens can also be obtained from an indwelling catheter. Sterile catheterized specimens. When a sterile specimen is ordered and the patient does not have an indwelling catheter in place, the patient is catheterized by you as a nurse. 24-hour urine specimens. All urine is collected in a collection bottle for a 24-hour duration. Strange specimens. If a patient is suspected of having a urinary stone, then the urine is strained when the individual is voiding. You can find this figure 29.3 in your textbook on page 545. This is a picture of urine collection devices. Box 29.2 in your textbook on page 545 shows some common abnormalities found during conducting a urinalysis. Please familiarize yourself with these terminologies. So glucosuria refers to glucose in the urine. Proteinuria refers to the presence of protein. Hematuria refers to blood in the urine. Pyuria refers to pus in the urine. And ketonuria refers to the presence of ketones in the urine. So when you are assessing your patient, what are some things you're going to be concerned for in regards to assessing their urinary elimination status? You're going to look at the individual's pattern of elimination. Are there any incidences of urinary incontinence or frequent urination? Is the individual complaining of burning during urination? Do they have a sense of urgency? Document the time of day for elimination and assess the total daily fluid intake. Okay, quick fact checks for you all. Question number 1. Let's think about the urinary system. What is the urinary system made of? Which structures? Is it A, B, C, or D? I'll give you all a moment to answer this. Hopefully you all get the answer is A, right? So the urinary system is made up of the kidneys, the ureters, bladder, and urethra in both the male and female. Next question. Erin's patient has been complaining of burning when she urinates. Her doctor ordered a urinalysis which shows pyuria. These results indicate what? Is it A, there's an increased amount of protein? B, liver disease or an obstruction of the bile duct? C, is there blood in her urine? Or D, is there pus in her urine? Do you recall what pyuria means? Okay, great job. So the answer is D, pyuria. So that means that there is pus in the urine, right? If you're having troubles understanding the definitions of these abnormal findings in the urine, I think it's a good idea to make yourself some flashcards and familiarize yourself with these terminologies. Again, the abnormalities commonly found in urinalysis can be found in your textbook on page 545, box 29.2. There's a very nice box there with some definitions. Familiarize yourself with these terminologies. Great. So now we're starting lesson 29.2, catheterization and managing urinary incontinence. In this section, the greatest takeaway for you would be to acquire information regarding how to insert an indwelling catheter using the sterile technique. We'll go over that process briefly, and ultimately, when you're in the clinical setting practice, you will have an opportunity to perform this actual technique. We'll go over the process of performing catheter care. Also, information on what you would teach a patient on how to perform Kegel exercises and what does that terminology mean. All right, so let's move on. All right, so what are some types of urinary catheters and specimens? You can find this information in your textbook on page 553. Catheters are come in a variety of sizes, shapes, and also they can either come in as plastic or rubber. Some catheters are also Teflon coated. Okay? They are sized using what is called the French system. So when you hear a catheter is referred to as a average size of either 14 to 16 French for an adult woman or 18 to 20 French for an adult male. Familiarize yourself with this list of catheter types. In regards to the specimen types, we've already reviewed this information. Figure 29.8 in your textbook on page 554 contains these pictures. These are pictures of common urinary catheters. You have your single lumen, what is referred to as your double lumen, and then your triple lumen catheters. Figure 29.9, side lying position for catheterization. This can be found in your textbook on page 563. So this figure 29-10 is found in your textbook on 564. This is a picture of what is called a suprapubic catheter. This catheter may be used for urinary drainage following gynecological or bladder surgery. And the difference with this is actually inserted through the abdominal wall by a surgeon. The suprapubic catheter is sutured to the skin at the time of insertion as well. As you can see here in this figure, it is directly inserted through the abdominal wall. So urinary incontinence, what does that mean? It's just a fancy terminology for stating there's loss of normal bladder function or bladder control. So individuals who have urinary incontinence can certainly be affected with body image disturbance, be at increased risk for impaired skin integrity, and also increased risk for infection. Incontinence may be temporary or permanent, and also may be corrected by surgery. As a nurse, an important role for you would be educating your patients and performing the Kegel exercises. Familiarize yourself with what is involved in educating your patients when it comes to Kegel exercises. Kegel exercises is found on page 569 in your textbook. Performing Kegel exercises regularly may actually reduce or even stop incontinence for some patients. Follow the techniques in educating your patient. You'll teach your patient how to concentrate on stopping the urine flow when voiding by having them tighten up their pelvic muscles. They can do this exercise by squeezing the muscle and holding it for 10 seconds. 10 seconds on, and then they'll relax it for 10 seconds, and so forth. Ultimately, doing this exercise 3 times a day can certainly help your patient with improving their incontinence issues. Urinary diversion is necessary when the bladder must be removed or bypassed for one reason or another. When urinary diversion is performed, one or both ureters are implanted into the abdominal wall, the bowel, or a portion of the bowel that forms a pouch. In these circumstances, skin care is important and it depends on the type of diversion. The ultimate importance of documenting your patient's care. Documentation would include documenting whether or not the individual is voiding normally, whether there's an indicative problem such as dysuria, whether the patient is continent or incontinent. You certainly want to document the urinary output amount, if you perform any bladder irrigations, and also if there's presence of any kind of indwelling catheter. don't forget, if you remove a urinary catheter, be sure to document that process as well. We're down to the home stretch here. Question number 3. Brenda is making rounds for her post-operative patient. She notices her patient's Foley has drained 90 mL in 3 hours. Which statement is correct? Recall what is the expected production of urine within an hour so you can answer this question. Is the answer A, there is a severe decrease in the urinary output? B, there is an average amount of urine output? C, there is a slightly above average amount of urine output? Or is it D, there is an excessive amount of urine for this post-operative patient? The answer is B. There should be an average hourly amount of 30 mL per urine output. In 3 hours, 90 mL will certainly be an average for any adult. Let's move on to the next question. Question number 4. Aaron's patient will be going home today with a catheter. All of the following are true regarding a Foley catheter except A, it is the most common type of indwelling catheter. B, it has 2 lumens. C, the balloon is inflated to 15 mL. Or D, it may be used for suprapubic catheter drainage or suprapubic drainage. The answer is C. The reason for this answer is because the balloon is inflated 5 to 10 mL, not 15. Foley catheter is the most common indwelling catheter. It does have 2 lumens and it may be used as a suprapubic drainage. Question 5. Bruce's patient needs a condom catheter. This type of catheter is used when A, the patient cannot void, B, a man or female has bladder surgery, C, a female is incontinent, or is it D, a male is incontinent? The answer is D. A condom catheter is only used for males, and this catheter is used when the male is incontinent and cannot void on their own. The end. I hope you enjoyed this presentation on promoting urinary elimination.